GLP-1 medications are often described as weight loss drugs, but that label hides the more interesting story. These medicines affect blood sugar, appetite, body weight, and other systems connected to metabolic health. One question deserves much more attention. When a number on the scale falls, what exactly is being lost? Today, we are separating evidence from internet promises. This is not a recommendation to start, stop, or change any medication. It is a map of the evidence. What GLP-1 signaling does, why these therapies can reduce weight, what the research says about metabolic benefits, and where caution matters. The goal is not to make the treatment sound miraculous or dangerous. The goal is to make the decision more understandable. To understand the medications, start with the hormone they imitate. GLP-1 is an incretin hormone released from the gut after nutrients arrive. In normal physiology, incretin hormones help coordinate the response to a meal. GLP-1 has effects that reach beyond one organ. It is involved in insulin secretion, appetite, food intake, stomach emptying, and fluid handling. The medications use this signaling system in a stronger and more sustained way than the body's brief natural signal. One of the most established effects is glucose regulation. The supplied reviews describe GLP-1 receptor stimulation as increasing insulin secretion when glucose is elevated and reducing glucagon-related effects. In people with type 2 diabetes, pharmacologic stimulation of the receptor can lower blood glucose and improve glycemic control. That glucose-dependent feature matters because the drug is not simply forcing the pancreas to release insulin at all times. It is acting within a meal and glucose regulation system that is already designed to respond to changing blood sugar. In practical terms, this means a GLP-1 medication is not just an appetite suppressant with a fashionable name. Its metabolic effect includes improving the way the body handles elevated glucose. But improved glucose control is not the same as curing diabetes, and a good response in one person does not tell you whether the same treatment is appropriate for another. The indication, dose, other medicines, and medical history still matter. The second major pathway is appetite. The evidence describes GLP-1 as reducing food intake and appetite, while also slowing gastric emptying. Those effects can change how quickly a person feels full and how much food feels satisfying. Over time, lower food intake can produce weight loss. That sounds simple, but it is biologically important. The medication is changing signals involved in hunger and meal regulation, not merely asking a person to use more willpower. The clinical trial literature summarized in the supplied review supports GLP-1 agonist for weight loss and reports improvements in hyperglycemia and insulin sensitivity. The same review describes benefits involving blood pressure and broader cardiometabolic and renal protection in relevant patient groups. These are meaningful outcomes because metabolic health is not one number. It includes glucose regulation, body weight, blood pressure, and the complications that travel with obesity and type 2 diabetes. So far, the story sounds straightforward. Better glucose regulation, less appetite, and clinically meaningful weight loss. But the next question is where that weight comes from, and whether the change improves function as well as appearance. A 2024 review focused on lean body mass found that the amount of lean mass lost during GLP-1-based weight loss varies considerably across studies. In some reports, lean mass reductions represented roughly 40 to 60% of total weight lost. In other studies, the proportion was approximately 15% or less. That is a wide range, and it is one reason a single social media claim about muscle loss cannot represent every patient or every medication. There is another complication. Lean body mass is not identical to skeletal muscle. Lean mass measurements can include organs, bone, fluids, and water in fat tissue. So when a study reports a change in lean mass, it does not automatically mean the same percentage of contractile muscle disappeared. The measurement method, the person's age, disease status, starting body composition, and the amount of weight lost all influence how the result should be interpreted. The same review says contemporary magnetic resonance imaging evidence suggests that skeletal muscle changes with GLP-1 based therapy may be adaptive in context. Muscle volume reductions can be commensurate with aging, disease status, and the amount of weight lost. At the same time, improved insulin sensitivity and reduced fat infiltration in muscle may contribute to better muscle quality. That does not make muscle preservation irrelevant. It means the honest question is not only how much muscle changed, but what happened to strength, function, and quality. This is where the conversation should become more individual. The review identifies older age and greater disease burden as factors that may affect who is an appropriate candidate, particularly when sarcopenia is a concern. During substantial weight loss, clinicians may need to pay attention to muscle health rather than treating every kilogram as an equally good outcome. A smaller body is not automatically a healthier body if strength and function are being lost. The broader evidence describes GLP-1 as a class with multiple metabolic effects, including glucose-dependent insulin stimulation, reduced appetite, reduced food intake, and effects on fluid handling. Reviews also describe potential cardio and neuroprotective and anti-inflammatory effects. But those broad biological possibilities should not be confused with a guarantee of a specific clinical outcome for every person. A mechanism can be promising while the actual benefit depends on the medicine, the patient, the dose, and the condition being treated. The 2026 World Health Organization guideline supply for this script recognizes obesity as a chronic, relapsing disease and says GLP-1 therapies can provide clinically meaningful weight loss and broad metabolic benefits. It recommends long-term GLP-1 therapy combined with intensive behavioral therapy to maximize and sustain benefits. But both recommendations are conditional. The guideline highlights limited long-term data, cost, equity, health system readiness, and differences in patient priorities as reasons the decision cannot be reduced to a simple yes or no rule. The word long-term is important. If obesity is treated as a chronic, relapsing disease, then the useful question is not only, how fast did the weight come off? It is also, can the plan be sustained, monitored, and adapted? The guideline emphasizes integrated, person-centered care. That means medication is one part of a broader strategy, not a replacement for understanding glucose, nutrition, movement, sleep, mental health, and the conditions that made treatment necessary in the first place. The evidence also makes clear that medication alone cannot solve the global burden of obesity. The WHO guideline places GLP-1 treatment alongside behavioral, medical, surgical, and other interventions, with prevention and management of comorbidities. It also emphasizes that access must be equitable and that health systems need to be prepared for long-term care. Effectiveness in a clinical trial and access to a safe, sustainable treatment plan are related, but they are not the same thing. So what should a viewer take away? First, GLP-1 medications have real evidence behind their effects on glucose control, appetite, and weight. Second, the wider metabolic benefits are clinically relevant, but still need to be interpreted in context. Third, lean mass deserves attention, especially in older adults or anyone already vulnerable to sarcopenia. And fourth, the safest version of this conversation is individualized, the right medicine for the right indication, with follow-up that looks beyond scale. GLP-1 medications are not magic, and they are not meaningless. They are powerful tools built around a real metabolic signaling system. The evidence supports benefits for glucose regulation, appetite, weight, and related outcomes, while also asking us to consider muscle, function, long-term care, and access. The right question is not only how much weight you want to lose, but what better health should look like for your body and your life.